So I'd like to begin with a brief review of the National Comprehensive Cancer Center guidelines as pertinent to HCC via the 2021 updates. And so in my mind, I like to think about these as being patients stratified based on whether or not they're transplantable or resectable. Let's begin with those who are potentially operable by performance status or comorbidity. As Dr. Geller described previously, we do additional stratification based on Child-Pugh classification and the presence or absence of portal hypertension. And then if resectable, that is, of course, the preferred treatment as he described. However, locoregional therapy, specifically ablation, is an alternative in this specific group of patients. Moving on to those who are unresectable, either due to inadequate hepatic reserve or tumor location, we of course do the transplant evaluation. For those who are unfortunately not transplant candidates, again, we kind of come to locoregional therapy, including both ablation and arterially directed therapies as primary treatment modalities. And for those patients who kind of correlate to the BCLC advanced stages, those with liver confined disease, but who are inoperable with poor performance status, multiple comorbidities, or even those with minimal or perhaps uncertain extrahepatic disease. Again, we see that locoregional therapies, including ablation and arterially directed therapies, are going to be the hallmark of treatment. And so I'd like to come back to the BCLC, which I was referring to. This is an updated version from 2021, and you can see how they substratify these patients and kind of divide the treatment algorithm based on staging, which kind of comes down to a few factors, including the number and size of the HCC lesions, the Child-Pugh status, as well as the performance status. The left side of the chart being those who are potentially curative via ablation, resection, or transplantation. In the intermediate stage, where you reach multinodular disease, chemoembolization, and I would add radioembolization is another option, before you reach advanced stage, where you're looking more at systemic therapies. And as you can see, too, the overall survival is best at the left side of the chart and decreases as you reach terminal stage. Now, for me as an interventional radiologist, I'd like to simplify this into early, intermediate, and end stage. And so when we talk first about the early stages, those who are potentially curable, let's talk about ablation as an alternative to surgery. So percutaneous ablation offers a high probability of complete response for lesions less than 3 centimeters, looking at 85 to 95% rates of complete necrosis. Contrary to some prior concerns about tumor dissemination, the probability of dissemination via percutaneous access and approach is kind of case reportable. And of course, there's less morbidity than surgical resection given the percutaneous techniques. Just a quick example here, you see in the top left panel a hypervascular hepatocellular carcinoma. You see that it's focally hypoechoic on ultrasound, and you can use either ultrasound or CT guidance to place probes, either radiofrequency or microwave, bracketing the lesion, which will then deposit thermal energy to result in tumor destruction. And the final panel here, of course, is showing kind of a post-ablation treatment zone with a scar and no viable tumor remaining. So what's new in the field of radiofrequency ablation and percutaneous techniques? Well, we do have some newer devices, such as curved electrodes, which can help us navigate around areas which were previously considered to be not ablatable due to proximity to either critical structures or vascularity. In addition, we have directional microwave probes now that we can use. Just to give you a quick example, if you had a surface lesion like Dr. Geller showed in one of his laparoscopic images, to do ablation would be difficult because of kind of bleed through of the heat sink into adjacent structures such as diaphragm or colon. With a directional ablation probe, you can then place that probe on the surface and direct the area of ablation specifically away from any danger or critical areas, which you can kind of see graphically depicted in this ex vivo specimen. So coming back to the NCCN guidelines, again, I'm not going to read this, but I'm going to pull out what we talk about for the footnotes for ablation specifically. And so what they're saying is in a well-selected group of patients with small, properly located tumors, ablation should be considered as a possible definitive treatment in the context of a multidisciplinary review. So how do we break this down? Let's talk about those less than 3 centimeters. These are potentially curative if they're in a location amenable to ablation, knowing now that we have expanded options with their new tools. For those with 3 to 5 centimeter lesions, combination of ablation and arterially directed therapy is also potentially curative. And for those with lesions greater than 5 centimeters, ablation is not recommended. So let's talk about the contemporary types of ablation, specifically Y90 ablation or radiation segmentectomy. So what we're talking about here is delivering an ablative dose of yttrium-90 radioembolic, which, as again, Dr. Geller kind of previewed, this is delivery of beta-emitting microspheres, essentially intra-arterial brachytherapy. What it's doing is providing local high-dose tumor irradiation. Millions of spheres are delivered, and that number can be modulated based on the size and area to be targeted. And each is going to treat a 2 to 11 millimeter radial area from the site of deposition. So previously with Y90 therapy, what we would do is get into just the right or left hepatic artery and treat the entire lobe, the entire area with HCC-bearing parenchyma, and you would be limited by the fact that while you are targeting the tumor, yes, you're going to get a lot of collateral or background radiation to non-diseased liver, or I should say still diseased with cirrhosis, but not bearing HCC. And so that would limit the actual dose you could deliver to the tumor because you have to modulate based on preserving the background liver function. What we're doing contemporarily in our institution and many others across the country is delivering Y90 therapy now in a much more selective and segmental fashion. If you can specifically catheterize those vessels feeding the tumor and spare much more of the surrounding parenchyma, you can then up the dose to deliver a truly ablative dose to both the tumor as well as a small margin of healthy liver, with the idea being that this can kind of equate to what would be essentially a surgical segmentectomy, but achieved via radiation therapy. There are numerous papers that support this technique, and I'd like to focus on this one published in Hepatology by Michael Vush. This is a retrospective study looking at 102 patients, kind of evenly split between Child-Pugh A and B. Most of the tumors were in the hepatic dome, emphasizing the peripheral nature, and they were solitary with a median size of 2.5 centimeters. And so compared to the old style dosing of a lobar treatment, which would be about 100 gray that you could safely get away with and not really damage the background liver, they were selectively administering up to 242 gray for a median dose. Of those 102 patients, 33 went on to transplant. In all 33 of those explants, you saw greater than 90% pathologic necrosis within those lesions, with a threshold dose of 190 gray being noted to achieve that degree of necrosis. So a quick example of what this would look like. On the upper left panel, you see a hypervascular HCC in the dome. You can see a very specific, super selective catheterization with a very targeted and narrow zone of delivery of the Y90, targeting both the lesion as well as a small margin of surrounding tissue. And then several months afterwards, what you see looks almost like a resection site. You see local scarring, absence of any viable tumor, and what essentially looks like I said, resection achieved via brachytherapy. So some of the most exciting data to come out has kind of evolved our understanding of the dosimetry and the technique for radiation segmentectomy. I'd like to focus on the legacy study today, which was recently published in Hepatology. This was a multi-center single-arm retrospective study looking at unresectable HCCs less than 8 centimeters. A pretty well-matched cohort of Child-Pugh A, BCLC A, and C lesions, or patients with pretty good performance status, median age of 66 years. Exclusion criteria included no prior treatment and no extrahepatic disease. And really the key for this was that the median dose delivered in a segmental fashion was now 410 gray in the study. So their primary endpoints were objective response rate by localized M-RECIST criteria, as well as duration of response were the same. So coming to the results, if you look at the overall objective response rate, for best response, you're looking at 88.3%, which is an excellent, excellent number. And if you look at best response stratification, for those with complete response out of this cohort, 84%, 136 patients, 7 with partial response, or only 4%, and 0 with stable or progressive disease by localized M-RECIST criteria. If you go on to look at the secondary additional primary outcome, which was duration of response, you're looking at a median of 15.1 months and a duration greater than 6 months, and over 3/4 of these patients at 76.1%. Kind of showing the data a little bit differently, you can see this waterfall plot. This vast wall of green is showing you all of the patients with complete response. The purples are the handful with partial response, and what you don't see is any patients in the red or the pink, the yellow or the pink, with either stable disease or progressive disease. The small circles are indicating that subset that went on to transplant or resection. So if you look at the overall survival, which actually wasn't the primary outcome of this study, you still have very impressive numbers. A 93% overall survival rate in those patients who did go on to transplant or resection following Y90 radioembolization at 3 years. That's depicted by the dark blue line here in the top of the graph. And even in those patients who didn't go on to transplant or surgery, you still see a very respectable 70% overall survival rate at 54 months post-therapy. So an additional interesting paper that kind of did a subset analysis of the legacy cohort was looking at the correlation of absorbed dose to pathologic necrosis within this group. And so the first chart here is depicting those patients with an absorbed dose of greater than 190 gray showed a much higher rate of complete versus incomplete necrosis. And if you look even further and separate into those who received greater than 400 gray, you had 100% complete necrosis response in lesions treated with greater than a 400 gray to their specific targets. So what do we take from this? The bottom line is that dosimetry matters. High dose is necessary to achieve ablative or curative responses with these lesions. This is the other most exciting trial to be published in 2021 that came out in the Lancet Gastroenterology and Hepatology. And this was the Dosasphere Trial. It was a randomized, multi-center, open-label phase 2 trial comparing personalized versus standardized dosimetry, personalized being greater than 200 gray and standardized being the old-style 100 gray glow bar treatment. So let's take a look again. This is a 4-center randomized controlled phase 2 trial, well-matched patient cohort, and randomized 1-to-1 to the standard dosimetry arm, which is a goal of 120 gray, versus the personalized dosimetry arm, which is targeting greater than 200 gray to the lesion with limited background dose. And so looking at the primary endpoint for this study, which was index lesion response rate at 3 months using EASL in the modified intent to treat group, you can see almost a 2-to-1 improvement in complete and partial response in the blue bar, which is the personalized or higher dosimetry, versus the standardized or kind of lower old school dosimetry. And so very good results here, and carried out to objective response rate as well, 71.4%, pretty much on par with the legacy cohort. And although this was, again, not the primary objective of the study, overall survival separated early and stayed separated. This is the kind of curve you want to see for overall survival for a therapy. And so showing personalized dosimetry median overall survival of 26.6 months versus standard dosimetry at only 10.7 months. So with this legacy and Dosasphere data, where did this impact the NCCN guidelines? Well, we now have a new addition to our line here with specifically with radioembolization, delivery of greater than 205 gray to the tumor can be seen with an associated increased overall survival. So moving on to adjuvant therapy to transplant. For those patients who, again, are not potentially resectable but could be transplant candidates, bridge therapy may be indicated to kind of keep them on the list. And so let's talk about this a little bit more in detail. The goal of transplant is to, of course, remove all of those intrahepatic tumor foci and remove the background oncogenic liver, which is cirrhotic. Survival is similar to liver transplant for non-cancer indications, but the problem, as Dr. Geller described, is the scarcity of donors and the fact that patients progress off of the list based on the Milan criteria. And so locoregional therapies play a role to decrease tumor size, not only to get them onto the transplant criteria, but they also allow them to receive mild exception points. So what is the evidence for downstaging? This is a meta-analysis published in Hepatology that showed improvement in 1 and 5 year overall survival rates post-transplant versus transplant alone when downstaging was added. Another systematic review showed about a 48% success rate of downstaging and getting patients to that magical transplant eligibility. And then finally, by Mazzaferro, the original creator of the Milan criteria, this is a phase 2b/3 trial published in Lancet last year that showed overall survival in those with downstaging by any modality compared to transplant alone was improvement in 5 year overall survival of 78 versus 31%. So downstaging works is the bottom line. This is a study looking at liver transplant following Y90 radioembolization as a downstaging modality, retrospective single center study, but they looked at 270 patients following liver transplant who had undergone Y90 prior to that. Of that group, most of them were bridged, some of them were downstaged, and overall survival rates looking at 3, 5, and 10 years of 84, 77, and 60%. Very good numbers. Those patients who had extensive or complete necrosis did have better recurrence-free survival. And the bottom line from this paper was that Y90 is an effective therapy for both bridging and downstaging. And so let's talk about intra-arterial therapy as an adjunct to resection. So a new concept that I'd like to speak about is radiation lobectomy, which is a novel neoadjuvant technique to facilitate resection. So as Dr. Geller eloquently described, liver resection is the best option if you're a candidate. Your 5 year survival is excellent. However, a lot of folks are limited by their future liver remnant. And so this is where Y90 can come in. You can do a lobar infusion, which is not only going to treat the entire affected lobe, but it's going to allow for contralateral FLR hypertrophy while controlling the tumor during the time to resection. This is in contrast to portal vein embolization, which is kind of the older technique described, which unfortunately can result in a lot of progression of disease by the time you get to that hypertrophy of the contralateral lobe. So by treating the disease and allowing hypertrophy at the same time, you have a greater cohort of patients who ultimately become eligible for resection. So here's the kind of a visual example of what I mean. This is a focal lesion with a very small FLR if you were to do a right lobectomy of only 34%. Treated with radiation lobectomy, you now have a 4-month follow-up, a treated lesion, and FLR that's increased up to 69% of what it was previously. So what are the surgical advantages of radiation lobectomy? Well, you have a tumor shift from major vessels, which optimizes your RZO or margin-free resectability. You also have tumor control prior to mobilization or manipulation of the liver. As Dr. Geller again showed, you saw how friable and soft those tumors are. If that tumor is destroyed before you resect it, the odds of spilling lesion in small cells is much better. The induction of FLR hypertrophy also limits the risk of post-op tumor progression by that rapid post-op liver regenerative activity that can happen when you do a large hepatectomy. Here's a specific example from our institution, a patient with multifocal disease, a very small left lobe remnant, treated by my colleague, Dr. Dunn, with intra-arterial radiation lobectomy, high dose to the right hepatic lobe. You can see the deposition on the nuclear medicine scan following Y90 administration. And then you can see the hypertrophy of the lateral segment within 3 months, as well as treatment of these lesions, which no longer enhance. And kind of critically for the surgeons, the feedback we got was that when they went in, this is their intraoperative laparoscopic image for this patient, you can see a very clear margin, healthy liver FLR, and very clear demarcation between the treated radiation lobe, which makes resection, I don't want to say a breeze, but a lot easier when you can see that kind of margin. So what about the safety of hepatectomy after radioembolization? This is a very small cohort study of only 12 patients, but they showed no post-hepatectomy liver failures. Again, an area of further study, but preliminary data suggests that this is safe and effective. So let's talk about those folks who are in the intermediate stages where we're looking at chemoembolization and radioembolization for treatment. These are older data, but this is kind of the seminal papers that established the role of transarterial chemoembolization in unresectable hepatocellular carcinoma. Well, ultimately, what do I tell my patients derived from these trials is that you get basically a 2 times increased rate of survival at 1 year, looking at roughly 60 versus 30% based on these numbers for those who undergo TACE versus best supportive care. So what are the contraindications to TACE? A poor performance status, ECOG greater than 2, large tumor burden greater than half of the liver, main portal vein thrombus, and the presence of extrahepatic metastasis. What about Y90 for intermediate stage HCC? We're talking about whole liver or lobar infusions for multifocal disease in the BCLC algorithm. This is a study looking at comparing chemoembolization versus radioembolization, looking at time to progression, favoring radioembolization, 13.3 months versus 8.4, with a higher quality of life. Another study comparing chemoembolization with radioembolization. This was a prospective randomized controlled trial looking at unresectable HCC not ablation candidates, with the primary endpoint being time to progression. And what they showed is very significant numbers. Look at this chart. You can see the early and progressive separation in the Y90 versus the TACE cohort. Time to progression of greater than 26 months in Y90 versus 6.8 months in conventional TACE. So what are the contraindications for Y90? Well, again, poor performance status, ECOG greater than 2, or if you're doing a lobar treatment, bilirubin greater than 2. This used to be very dogmatic, but with the advent of segmentectomy, you can even get away in doing this with patients with very high bilirubins, given that you only are going to treat a very small volume of liver. Toxicities of Y90 include fatigue, lasts about 10 to 12 days, which can be mitigated with steroids in those who can take them. Some mild abdominal pain and discomfort, much better than the post-embolization syndrome from TACE, which can be significant. Fevers and night sweats. And then one thing that always comes up is concern about radiation-induced liver disease. Really is only about 3%, but it only pertains to those who are getting bilobar treatment, which is kind of no longer performed clinically. So how do I decide TACE versus Y90? For single focal tumors or either multifocal tumor confined to one lobe, Y90 offers clear advantages with respect to time to progression, bridging, downstaging, as well as potentially curative treatments in the session of radiation segmentectomy. For those with multifocal bilobar disease, in order to avoid that radiation-induced liver disease potential, TACE may be a better option for these individuals. For those with vascular invasion, either branch or even main portal vein invasion, Y90 can penetrate and treat those lesions much better than TACE. And for those who have lobar disease but high bilirubin, TACE can be done in that setting, whereas Y90 still has that bilirubin cutoff for lobar treatments. We see the advantage for downstaging. Now, Y90 does have a few more steps involved, and patients may have to do up to 2 visits, although that can be actually done in one therapy. But for those with poor compliance or a large central tumor, TACE may be preferable. But for those peripheral tumors and those with potentially even a kind of a marginal performance status, Y90 is going to be superior. So this is kind of the summary where we stand with respect to our local regional therapies. Really, at every stage of disease, we have options. And so I'd like to talk a little bit about combination therapy, specifically how this compares with Sbrt, which future speaker Dr. Renz is going to be speaking about. And this is again from the NCCN guidelines in 2021. There's growing evidence of the usefulness of Sbrt, or external beam therapy, in management of patients with HCC, and it can be considered an alternative to ablation or embolization when these therapies have failed or are contraindicated. Now, while that sounds a little bit kind of sour on Sbrt, I do want to mention that these therapies are complementary. Both tumor location, number, and vascularity plays a key role in choosing which therapy is going to be appropriate. I think Sbrt is excellent in treating very small lesions completely non-invasively. Although we pride ourselves in IR and being only minimally invasive, Sbrt, there's nothing going in the patient, period. For intra-arterial therapies, however, if you have a larger or more numerous lesions, I do think that they have a distinct advantage. And then multiple other factors such as single versus multi-day therapy and patient preferences are going to factor into the decision-making. For lesions greater than 4 centimeters, Sbrt and TACE are very synergistic with good results, which I think Dr. Renz is going to speak about. But the bottom line is there's no comparative data yet as the literature evolves. And all we can do is say that multidisciplinary discussion is ultimately the key. And having a good working relationship between your IR and radiation oncology colleagues is going to be very important for those BCLC intermediate stage patients at your tumor board. So talking about combination with systemic therapy, there's a few papers to mention. This was a large meta-analysis looking at combining chemoembolization with sorafenib and unresectable HCC. Again, looking at very large numbers, multiple studies were included within this. And really what it comes down to, kind of their conclusion was that combination therapy improves overall survival with a combined hazard ratio of 0.74. This is another study, very small cohort, but looking at the safety and efficacy of locoregional treatment during immunotherapy with nivolumab. So it did show safety within this, and that was really all they looked at. And what I would want to encourage our audience to look at is multiple randomized controlled trials, which are out there right now, comparing all these combinations. And so when we think about the BCLC, it may seem rather rigid with all of these various treatment arms, but the truth is there's a lot of lateral crossover and kind of multimodal network mapping within this algorithm. And a few key studies to point out that are looking at combining therapies, including TACE plus durvalumab and bevacizumab in the intermediate group, TACE and nivolumab, and then Y90 and sorafenib in the advanced group. And so it's an exciting area. We're excited to see where things progress. And with that, I will wrap up and take any questions if there are any. Thank you very much.